there, but my name's Tiffany Bystra. I am an occupational therapist and an OT content developer for USA. Prior to being in the content development role, I worked as faculty for USA at the Austin campus for a little under 3 years. But I'm just so pleased to see people on the call and at least have some level of interest in the topic. Today, I'm going to be talking about what rehab professionals can learn from a discipline called science and technology studies. And so just before I share my screen, kind of guide us through the slides, I want to give a bit of background on where science and technologies just came from. In addition to doing content development, I'm a PhD student in bioethics and health humanities at the University of Texas Medical Branch. And a few terms ago, I took a science and technology studies course. And I have to say, looking through the lens of a rehab professional, I couldn't help but draw so many connections that I think that OT professionals would be really interested in engaging some of the science and technology questions that come up and its relatability to rehab. So here we go. I'm going to try and share my screen. And I do need my notes. And so here's hoping that I can do it in a way. Do you see my notes or is it just the slide?
Just a slide. You're good.
Oh, love it. Thank you. All right. Now let me make sure that I can see my notes. Yeah, I can. Okay, so some learning objectives here are, it's my hope through this presentation that I can share some ways in which rehab professions and science and technology studies, which it's a mouthful to say science and technology studies, so I'll lovingly refer to it as STS, if you can remember that as we move forward. I'd like to explore how they converge. I'd also like to position rehab professionals as actors in a healthcare service delivery that draws heavily on science and technology. And lastly, I'd like to make the case for further study and knowledge sharing between rehab professionals and STS to help inform our clinical reasoning, the way we approach practice, and how we educate students. And so I just want to kind of set the scene and have you think for a moment about your own practice and your own teachings. In what way has science and technology interfaced with your work in rehab? Ask yourself, what are your views on science and technology broadly? Do you hold them as generally positive and innovative? Or do you see challenges that surround them, both in theory and practice? In what ways have you used your position as a rehab professional to affirm your affiliation to scientific standards with your clients? And in what ways have you used technology maybe as a signifier of being an innovative practitioner? Anyone on this call might have some degree of similarity in their answers, but I can almost assure there's going to be variances as well. And this will be according to our practice areas, our settings, the populations that we work with, and our disciplines. So it's my argument that rehab clinicians, educators, and students interact with scientific concepts and technologies that are associated with their respective professions. Scientific concepts inform many of our rehab approaches, including the identification of a hypothesis, developing problem statements, establishing differential diagnoses and rehabilitation, and the use of our clinical reasoning. Knowledge of scientific disciplines, including physiology and neurology, anatomy, are viewed as foundational for many rehab clinicians. And many practice settings and continuing education courses make science and scientific approaches a central focus of improving client care. Rehab clinicians, educators, and students also work with technologies, both in development and emerging technologies. Technologies can range in complexity from high-tech solutions to low-tech. However, when we think about stereotypically high-tech solutions, what's seen as most innovative in rehab, we might reference sophisticated technologies like neural recovery robots, robotics and exoskeletons, eSTEM modalities, wearable devices, 3D printing, telehealth platforms, the use of video fluoroscopy, and electronic health record platforms. As engagers in both high and low technologies and potentially reinforcing their use with clients, this makes rehab professionals actors in healthcare service delivery. And no, I don't mean actors as in theater, but rather in active engagement. We're actors in a healthcare service delivery that heavily draws from sciences and technologies. And so that brings me to STS, Science and Technology Studies. With rehab professionals being considered actors in care environments that draw on these science and technologies, opportunity lies for evaluation and engagement in interdisciplinary fields, even those outside of clinical practice, even those outside of rehabilitation, to optimize our understanding, our implementation, and critical analysis of these sciences and technologies. STS is a distinct field of study that seeks to explore relationships between science, technology, and society. STS philosophies and writings have laid scholarly groundwork to analyze and critique how science and technology have played essential roles in the acquisition of knowledge. STS draws from history and offers a historical appreciation of how scientific advances have come to fruition. It explores ethical dilemmas that have arisen because of technological development. And it also seeks to interpret policy influence that is instrumental to the care that's provided to our clients and our patients. And so I have a picture of this glass of water, for example. Almost any concept, topic, or product can entail some level of STS study and be appropriate for STS study. So a simple glass of drinking water is much more than that. It involves multiple levels of human intervention. Just think the construction of a water treatment facility, the development of chemical and processes related to turning dirty water into clean water that's suitable for human use. There's policies written to inform how water treatment or the investment in water treatment infrastructures ought to be conducted. There's conversation about what's seen as a suitable risk versus benefit on public health regarding fluoridation. And these are all just some examples, but almost every field of innovation and service has been touched by ideas of what innovation looks like, what solutions are presented in the face of a problem, how the presence of technologies shapes individual versus societal responsibility, and so on. And so here we are. How can we connect STS to our work as rehabilitation professionals? Think back to the question I asked at the very beginning of the presentation. In what ways does science and technology interface with your work in rehab? Inherently, STS has research agendas involving healthcare enterprises and clinical encounters. This includes inquiries on what qualifies knowledge as legitimated versus not worthy of being seen as credible. STS also analyzes societal and cultural perceptions of clinical and research institutions. STS is also invested in the designation of boundaries of scientific claims and how they're made and how they're substantiated. I'm positioning many of the examples of STS here as related to rehab professionals in a biomedical model, simply because it does make for a bit easier entry to understanding STS themes, because science and technology are made highly visible in those spaces. However, if you come from a practice setting that's more education, community settings, mental health. Just know that there's still a lot of understandings and application that can be drawn in STS. STS has high relevancy and influence in all types of spaces. For instance, the diagnosis of mental health conditions, the validation and rationalization of community-based practice models, and the literal construction of buildings and care spaces all have invested dialogue in what STS has to offer. Whoa, watch me get a little wild with my slides here. So that brings me to wanting to make it just a bit more explicit on how STS might relate to a client receiving inpatient rehab. They're receiving speech therapy, physical therapy, and occupational therapy while at an inpatient rehab facility. STS would engage and interrogate some of the following questions. How does the use of assistive technology shape the client's rehab experience? What assumptions do these medical devices reflect about the human body, including its ideals of function and aesthetics? What ethical imperatives are introduced when emerging rehab technologies are put into practice? Who is at the table in designing rehab solutions that make their way into practice? And what solutions do these technologies promise to address? Are they truly problems? Or in which situations might technology introduce new problems? How does the knowledge of rehab professionals shape treatment decisions? And what qualifies as an acceptably skilled approach to rehab? Whose knowledge counts in rehab decision making? And how does evidence-based practice and its constructs inform the hierarchy of what is seen as most credible? What assumptions about the body and rehab practice are made in the design and construction of inpatient rehab spaces and their infrastructure? How do understandings of disability influence the role of rehab as a whole? And what role does rehab as a concept play in the reinforcement of social norms about what is to be prevented or mitigated in the body? How does this play out in patients who acquire their disability versus those who live with disability from birth? And so a whole lot of questions, not so many answers, but it's my argument that rehab can certainly be a part of engaging some of these questions. We have unique perspective that can be really useful to interrogating some assumptions and some practices that lay at the heart of some of these STS conversations. And so moving beyond a specific individual client example, I just want to broaden the lens and relate it to a larger scale, especially on something that all of us, by nature of being human, are invested in, and that's aging. There's some scholarship. Kaufman and colleagues write about the relationship between technological advances and moral imperatives in the aging process. They state that technological advances have the potential to, quote, become a moral imperative for families as well as clinicians. Families have always been implicated in medical care and its social ramifications, but the fact that older lives are routinely extended today complicates the nature of familial obligation, end quote. So Kaufman writes a thesis here that's centered on technoscientific influences on aging as a concept. Putting moral imperatives into conversation can invite imaginations of what influence medical science and technology has on our lives, our ideas of what's possible and desirable, and how their instrumentality can affect society at large. What do these technologies mean for individual and public perceptions of what problem is being solved? Does normalizing the use of some technologies have implications for our own personal and individual responsibility in the management of our conditions, for societal attitudes, or for public policy? So I'm saying here that rehab professionals, we exist at a unique junction between medicine and life outside the hospital or clinic. As a bridge between one's illness state and their typical daily life, rehab has vested interest in concepts of normalcy, cure, and promise. Science and technology have an incredible amount of pull in defining the options that exist for people. Clients base their goals and their sense of hope on what is available, with many of us wanting the newest and most innovative options to restore us back to what was. Novel technologies promise to offer solutions. However, I assert that further interrogation of the root of the problem is often needed. Medical science and technologies are certainly a valid tool for intervention when weighed against the gestalt of someone's situation. However, medical science and technologies can perpetuate an overly medicalized perspective that disproportionately values stereotypic measures of function, quality of life, and independence. Disability scholars have long critiqued and engaged with concepts of normalcy. Kingelheim, in their work on the normal and the pathological, asserts that medical categorizations between what is normal and what is pathological are unfixed and non-manualized, but rather rely heavily on judgments and constructions of both history and value. He furthers that normal is not neutral or a baseline to strive for. Instead, normal is an evaluative standard with strong influence from our human context, including what we know from culture, from biopolitics, and from the socio-technological. Interviews with children born with congenital physical disability do reveal some instances of suffering when being made to prioritize normal ways of walking, normal ways of doing ADLs, and normal communication patterns, even when interventions and technologies imposed on them elicited significant discomfort. Reflecting on their experiences of growing older while living with a disability, many of these people cite a desire for more public acceptability of mobility, self-care, and communication modalities that are functional to them, even if they differ from the norm. I mention this example not to assert that ideals towards rehab are bad or that rehab as a premise is bad. I'm an OT. I'm invested in the important and amazing work that OT can do alongside people. Rehabilitation and its relationship with innovation can absolutely create opportunities for skill remediation for those who desire it. But let's relate this example of inducing suffering in a child with disability back to our previous framing of technological advancement and moral imperatives. To me, the question arises, does deviance from a norm demand negotiation back to normalcy? I don't have an answer to that question, but rather I think that rehab professions belong at the table in these types of STS questions. And so if rehab professions could find utility in these types of STS questions and wish to be a part of the conversation, here's just some examples of how we might engage. Rehab-specific examples include legitimated knowledge versus what is seen as not credible. And this introduces tensions in an evidence-based hierarchy. Randomized controlled trials are privileged as gold standard evidence. And while they have, great value and can be certainly really informative approaches taken, patient-reported experiences can be seen as less valuable or be put off to the side, even though they might capture really crucial insights about lived function and experience. This can also be seen in experiential versus professional knowledge. Someone just for example, with a spinal cord injury, who's become an expert in navigating their daily life, might offer really practical knowledge that clinicians or physicians might overlook or undervalue because it doesn't come from academic research and its rigors. Lastly, assistive tech design. Engineers and their technical expertise might be prioritized over user experiences. So it brings us to questions of how much are the end users being integrated into the design of products. For example, a prosthesis that performs well in experiment or in lab might still induce considerable discomfort or stigma in real life because it still counts as effective in research terms, but may have different usability in real life. We also are interested in how the boundaries of scientific claims are made and substantiated. So I mentioned earlier a medicalization of our patients and our clients. Rehab clinics can be perceived as spaces of correction or normalization, and that can reinforce ideals of able-bodiedness. So for patients or clients who see disability as a part of their identity, there may be differences, quite stark differences too, in how rehab is perceived or understood. Public perceptions of emerging tech, the robotic exoskeletons can be celebrated in media as miraculous. And while they can offer really helpful tools and modalities for people to reach their goals, there can also be a techno-heroic sort of narrative that really centers a cure of something over an adaptation. So this can shape how things are funded, what policies are put into place that prioritizes high-tech kind of sexy innovations rather than innovations that happen on a social support level or community resource sort of level. And lastly, here we see clinical authority versus community empowerment. Sometimes institutional rehab can undercut some of the peer-led initiatives like disability-led exercise programs that can otherwise complement formal services. Let's see here. We also have how boundaries of scientific claims are made and substantiated. So this boils down to defining what is seen as skilled or unskilled. An example of cognitive rehabilitation or art-based therapies can often sit at the edge of mainstream acceptance. And there's debate and a lot of conversation even in curriculums about what is sufficiently seen as evidence-based interventions versus something that's an alternative approach. So there's this categorization, these buckets that some interventions and some approaches lie in. And these are all constructed. There's definitions that are attached to these things, and they're seen as either better or less than. Clinical research versus design research. So kind of going back to the example I gave earlier, human-centered design, really including people who live with disability and who have their own lived experience into the design of products, into the design of technologies early on in the process is so important. Lastly, we see interdisciplinary tension. So certainly OT, PT, speech therapy, we all have, we share similar goals, but we have different approaches, and we can have different cultures of how and where we draw information from. And so there's a boundary negotiation that happens in the rehab professions that I think is worthy of more discussion, and it would be interesting to have an STS sort of lens to analyze how boundaries are drawn and what is useful versus where does boundary drawing maybe cause hiccups or confusions in not only professions, but in the clients and the teams that we work within. And so in closing, I'm reminded of some of the philosophical tenets that have been carried through my PhD program in bioethics. And epistemology is the philosophical study around knowledge and how we acquire it, what the limits of knowledge are. And it asks questions about what does it mean to know something and how we can be sure that our beliefs are true. And so I'm positing that through integrating rehab professions with STS, science and technology studies, that we can have a type of epistemic shifting where we can imagine new worlds in an ever-growing and ever-changing world. Our students, they want to know how they can take their understandings of rehab professions and best marry it with what they'll see in the real world. And I think that STS does a really nice job of capturing some of the nuances that come with science is rapidly expanding. We see this with artificial intelligence, and with that comes the development of new technologies that promise to offer solutions to problems. It's through this presentation that I hope that through introducing STS and its inquiries, it helps us imagine maybe new worlds of our role as rehab professionals. STS can help stoke a critical curiosity as essential actors in this healthcare arena that's deeply embedded in science and technologies as they intersect with normalcy and notions of cure. Rehab plays a unique and essential role between medicine and life outside of the hospital or clinic. How we engage with clients and how we teach future rehab professionals can perpetuate understandings about the body and what is desirable. And these are all questions that STS seeks to interrogate, and that rehab has an important perspective to talk about. I know that learning about STS has changed some of my perspectives about my role as an OT, and maybe some of the themes that were introduced here today may have gotten you thinking a bit more about this relationship between what we do, how we educate, and how that interfaces with a rapidly changing world that has many implications in science and technology. So with that, there's the references, and I will stop sharing just to realize how many people are on the call. This is a lot of people. I'm glad I couldn't see it before. I think I would have been more nervous. But yeah, I'll open it for questions.
You did a great job. Any questions for Tiffany? No, no questions. Oh, you got an applause. Thank you, Alexandra.
One thing, if people are thinking of questions too, I recognize throughout the presentation too that really it introduces just way more questions than it does answers. And I'll tell you, in taking the science and technologies course, that was something that I felt really frustrated with. I'm like, okay, but what is a practical solution? What is something that I can kind of sink my teeth into to make things better or be a better practitioner, a better educator? And really, at the end of the day, I think STS is, how should I say? It's a critical field that begs more questions, really, and it seeks to just study the relationship between science, technology, and society at large. And so, I think the types of questions that we ask can reveal like underlying assumptions that might get us closer to the answer. And so, for instance, with the aging example, a common technology that I think of is some of the wearable devices that we have to track our steps. And they can be wonderful tools to help us improve our activity and to keep us active. However, there's some kind of going back to that moral imperative is there can be some some of those like step challenges of like the 10,000 steps that people like really then strive for that 10,000 steps as a goal or a solution. Whereas let's say you go to your primary care physician, they now have a tool to say, hey, did you meet your 10,000 steps or not? So it introduces like a new obligation onto the person with this number and this measure and this objective being attached to it. And so while there may be, the argument that more is always better, motion is lotion, keep it going, what you don't use, you lose. With the introduction of this technology in the aging landscape, it just introduces a new standard and it can shift what the obligation then is to the aging individual. And so sometimes just by bouncing ideas off and having these conversations and asking the questions of who was involved in Fitbit designs and where does 10,000 as a specific number come from and how are these technologies then integrated into clinical encounters. I think that by just having discussion about it, which I think rehab professions like it would be such a rich contribution to have us at the table for some of these conversations. It can help us get closer to maybe answering some of those questions.
All right. Thank you so much, Tiffany. Oh, I have just one question. I'm in my first try at the DPT Flex program on the Austin campus. Interested in how these concepts apply across rehab fields. Do you think PTs and OTs work together to apply science technology studies when evaluating or integrating new assistive or therapeutic technologies?
Ooh,
Question.
that's a great question. I as part of the STS course that I took, I was curious because I kept thinking, gosh, as an OT, I have so many things to say about this, and I want people to know about what this looks like in clinic. I went to the literature and searched. I'm like, has there been conversations in STS about rehab, or has rehab had conversations about STS? And there was, sorry, it's just my alarm telling me to wrap it up. Um, there's I couldn't find one that was like discipline specific to say, yes, there was like formal contribution. I think in informally, we have some of these conversations, but it's not reflected in literature. It's not really reflected in what we see in like scholarly resources or even classes, really. But as rehab professionals, PT, OT, speech, we all, work in these systems that have some influence in technology. Skilled nursing, LTAC, like technologies have been developed to support prolongation of life and to support the achievement of functional goals and to manage our time and to manage staffing. These are all technologies and they have influence. And so I think that that's one thing that I would have to say is often in rehab and in USA too, we very much champion and applaud like interdisciplinary collaboration on these things. Whereas I think what I'm asserting is there's beauty in interdisciplinary collaboration between rehab professionals, but in those congregations of rehab professionals as a large, could we have bigger conversations outside of rehab, even more interdisciplinarily? That's, I think, a central thing that I'm thinking a lot about lately is, gosh, we have so many implications for daily life and how people move through their lives and how they move through healthcare systems and community-based care and mental health care. Like, we have influence and we have touch points along this way. So could rehab professions also be more engaged, more represented in larger philosophical questions and bioethical questions and care infrastructure, public health sort of things. And I think that we see that happening more as people grow in their own imaginaries of their career and wanting to extend out beyond clinic and be a part of those conversations. But yeah, I think that working together is always great and always something to be celebrated because we learn so much from one another. But within those congregations of what we call interdisciplinary between rehab professions, can we all come together and even have bigger scope and reach? Because we have so much to say.